at these problems, we have to begin their treatment bearing the end in mind, which is, of course, good if we can define the end. Unfortunately, this is not one of my quotations, but comes from the great Wick Alexander, who has introduced this philosophy of beginning with the end in mind into orthodontics already many, many decades ago, and we have the privilege to know him personally. And Wick's always said it's good to begin with the end in mind. It should be the same for all clinicians, regardless of the bracket system that is used or the philosophy of treatment we apply. What are we going to do? Well, of course, first of all, we have to provide our patients with a sound diagnosis. Then we have to develop an individualized treatment plan. And third, we all have to be able to manage our appliances efficiently. But when you take a look at these complex situations, maybe sometimes it's not so easy to have the end in mind right away. And of course, all these situations cause a compromised smile, that's clear. And the crucial question for all of us is, are we going to close the spaces or are we going to open them? We have tried to add a little bit to the evidence-based literature on the topic, as you can see here. And in general, we follow two principles. First principle comes from one of the icons in orthodontics, who unfortunately passed away some years ago, Sheldon Peck. He was one of my mentors for the Endo Society. And Sheldon, as a seasoned orthodontist, always said that it's always better to work with nature than to try to work against her, because in the end, nature is always going to win. And the second principle we try to adopt in our office is the keep it simple. Keep it simple, sir, principle. That, again, was not coined by us, but by Wick Alexander. I think many of you are familiar with this KISS principle, which is really a very good way forward if you have to deal with complex situations in your office. Try to think simply, or in other words, try to adopt the concept of less is more. Two principles we are following, and we have also two objectives in our minds. First objective we try to follow is to achieve symmetry, because symmetry is a proven concept in nature. It works well. Things that are symmetrical usually function very well as well. And the second objective is that we would like to finish with 28 natural teeth in the mouth of our patients, because for a modern human being, 28 natural teeth is a good number. So let's start the topic of missing teeth, first of all, with patients that present impactions or transpositions. I would like to start with Evelyn's post-treatment smile. Please take a look at the smile if you detect something that is disturbing you, that you don't like, or if you could consider this a beautiful smile. This is how she came to see us at age 14. You can see she presents a class 2 malocclusion and a significant arch length discrepancy when she smiles. She has also a significant arch length discrepancy in the lower arch, a lot of crowding, but the real problem you can evidence when you take a look at the radiographs. You can see, apart from the class 2 malocclusion, which is relatively severe, she presents with two very, very complexly impacted canines. It was the age before 3D, and we are not Superman or Superwomen like Stella Chaushu from Jerusalem. And I have already told you that we usually try to follow the principle that less is more. What could this mean for Evelyn, less is more? Well, it means that we are not trying to bring these impacted canines into the arch after cumbersome procedures to gain space. But the idea was to sleep well at night, not to risk any root resorptions or some adverse effects on the adjacent teeth, to be quick in our treatment, and therefore we decided to surgically remove these canines and to perform compensatory extractions in the lower arch, because there was crowding as well. And once this decision had been made, and Admittedly, it's not so easy to convince patients and parents to surgically remove canines at the age of 14. But once the decision is made, then the treatment is very straightforward. As you can see here, you won't see any sophisticated mechanics in my presentation. We just try to bond the brackets at the right spot. We have a straight wire system, and here you can see a little bit the history. And I hope you like the treatment result intraorally. I think we have established a good occlusion posteriorly. We have not compromised the width of the arch forms during space closure. And you can see on the panoramic radiograph post-treatment that we have not jeopardized the dentition. There's good root parallelism, and there is no major root resorption going on. 17 months of treatment is relatively fast. You can see that we were able to maintain the inclination of the upper and lower incisors as well during space closure. And if you take a look at the before and after smiles, you will probably agree that we haven't jeopardized her smile aesthetics. We have not compromised the projection of the upper incisors. She has a nice profile. We haven't dished in the profile with our extraction protocol. And here you can see 7 years in retention, that the overall treatment result is stable and that she's still happy with her smile. This is another patient, Bree. And you can see again there is some crowding in the upper arch. You can see she has a class 2-ish profile. She has a class 2 occlusion. What is the problem? Again, we have problems with the canine in terms of unilateral transposition in the second quadrant. Bearing in mind that we would like to keep our treatment as simple as possible. Less is more. What are we going to do? Here you can see her 4 years later, and the smile looks more or less the same. Like you look at it 11 years of age. I think you will agree on that. Haven't we done anything for her in the meantime? Just waited for eruption of the entire dentition? Well, we have done something, as you can see here. We have sent her to the surgeon to surgically remove the transposition canine, but we haven't touched her with any appliances, because our principle is that we would like to do as best as possible for our patients and not jeopardize their collaboration too much. So we are trying to find the right timing to start the treatment, which is now after complete eruption of the entire dentition, including the second molars. And then the deciduous canine in the second quadrant is removed, compensatory extraction of the first premolar in the first quadrant, as you can see here. And again, with very straightforward appliances, sometimes a little helped with some accessories coming from the segmental arch technique, like these very cheap uprighting springs that help you to level the curve of speed, that help you to gain more anchorage. We are closing the spaces. We always rely on a little collaboration of our patients. We think that no orthodontic treatment is possible without collaboration in terms of oral hygiene and some elastic wear. And here we are shortly before removing the appliances, and this is on the day of band removal. You might criticize that in the second quadrant nothing looks perfect, and you're absolutely right. Of course, we have to embellish our result with a little bit of gingivectomy and a little bit of composite bonding in order to mimic the position of the first premolar in the second quadrant, a little more being a canine. We have, again, not provoked any damage to the profile, despite the extraction of these 2 teeth in the upper arch. We have not jeopardized the projection of the incisors, and we have not jeopardized the width of the buccal corridors. And this is in accordance with what we can find in the evidence-based literature. This comes from Mauro Varela, the group of New Zealand, and they have established that indeed in well-managed orthodontic patients with or without extractions, we are not going to harm the soft tissue profile or cause any detrimental facial changes. And again, you always deserve to see the post-treatment radiograph. You can see that we haven't committed any harm to the dentition in terms of root resorption, and that the root parallelism is good. The upper wisdom teeth have now space to erupt, while of course in the lower arch, further down the road, the wisdom teeth have to be removed in order to finish with 28 natural teeth. And again, you can see that we were able to maintain the top of the upper incisors very nicely during space closure in the upper arch. And here the close-up that reveals that I guess nobody can really detect that the first premolar in the second quadrant is substituting the extracted canine. Smile is good, no difference between right and left. And again, a last patient to prove that sometimes less is more can be the right way forward. He came to see us because of his bimaxillary protrusion. You can see here just a screenshot from our dolphin program, just in order to show you that we really care about providing our patients with excellent records. What was the situation? Bimaxillary protrusion, as you can see here, class 2. And again, very dramatic situation in terms of bilateral transposition of the canine. And you can see the canine in the second quadrant is highly impacted, very close to the sinus, and a supernumerary first premolar in the lower arch. This is the situation. You can see bilateral transposition. Adopting the principle of less is more. Of course, you know already what our treatment strategy was. We removed the canine in the second quadrant and performed 3 premolar extractions. We didn't start this treatment right away, but we waited until complete eruption of the entire dentition because we don't want to burn the collaboration of our patients too much. And here you can see again, just straight wire appliances, nothing special, just trying to bond the brackets at the right spot. Sliding mechanics, sometimes helped with a little bit of intermaxillary elastics, and this is shortly before removal of the appliances, and you can see that this treatment approach has produced a nice occlusion, and this is what we would like to see on a regular basis. If we extract or if we don't extract, we would like to see, and you can only see it if you take this photograph from slightly below, slight interincisor contact, slight intercanine contact. And this should be the end, regardless of the bracket system we are using or the treatment philosophy we apply. Here again, to prove that this treatment approach has not jeopardized the dentition, which is very, very important, that we do not create any harm. And you can see when you take a look at the anatomy of the first premolar that probably it was a good idea to get rid of this highly infected canine, because we could have caused a lot of trouble to the patient. And again, we were able to maintain a good inclination of the upper and lower incisors despite the extraction protocol. And we have normalized the bimaxillary protrusive profile. Lip recumbency is much better now. Smile is nice. And again, we have not caused any damage to the width of the buccal corridors. And we're going to hear tomorrow a little bit more about what extractions can provoke or not provoke when I talk about the digital revolution tomorrow morning. We know from the literature, from the group of Jonathan Sandler, that in fact the idea, sometimes if we have canines in a bad position, to get rid of them is justified. This is a study that has evidenced the difference between the beauty or the aesthetic outcome of patients that have been treated with premolar extraction versus patients that have removal of the canines. A panel of dentists, orthodontists and laypersons judged the final treatment outcome, and the authors concluded that there was no statistically significant difference in the aesthetic outcome of patients that had undergone canine extraction versus patients that had undergone first premolar extraction. So sometimes, especially when the canine is in really bad position, it's a good idea to consider surgical extraction of these elements. Second group of patients that present with missing teeth are the patients with missing teeth due to agenesis, and again the crucial question is open, closing of the spaces. We think that nothing can cure all ills. We have to be very individual. Of course, if we have young patients like Sophie coming to see us with multiple agenesis, as you can see here, we would like, if possible, because we think biologically, and we know that the periodontal situation after space closure might be more predictable and more healthy in the long run, we would like to close the spaces, aiming for symmetry, as I told you before, and probably if we can achieve a dentition with 28 natural teeth at the end of our treatment. So this is Sophie, and you can see that it's a situation where if you are aiming at providing her with 28 natural teeth, you need to know if the third molar germs are going to develop. The idea would be to perform compensatory extraction of the upper right lateral incisor that is underdeveloped to preserve in the first quadrant, because 2 teeth are missing there, the E. But as I said, if we are aiming at 28 natural teeth, we have to make sure that the wisdom teeth are going to develop. So we have to wait a little before we start our treatment, making sure that the germs are visible on the radiograph. And then is the right time, after more or less complete eruption of the entire dentition, to start the treatment. And again, you see nothing special here. Sometimes we bond some accessories, these hooks here for controlling the top of the tooth a little better. You won't see any skeletal anchorage in my presentation because we are relatively reluctant. We try to come up with treatment mechanics from the old school days, probably, that can be very efficient. This is shortly before removal of the appliances. Treatment took 22 months. Of course, we had to close the extraction spaces nicely and parallelly, and this takes some time. Here again, you have to be permitted to see the post-treatment radiographs in order to make sure that we haven't committed any harm to the dentition, that our space closure was really nice and parallel. Unfortunately, in her, we lost a little bit of the top of the upper incisors during this relatively large space closure, but luckily they didn't have any negative effect on the profile. I hope you will agree on that. Smile at the end of treatment is not ideal. Of course, in these patients with agenesis, we have to send them to the restorative dentist to perform some gingivectomy and, of course, some restorations. We sent her to an excellent restorative dentist, relatively far away from Bolzano, who is very, very soft with restorations, especially in young patients. So you can see that just with 6 indirect composite restorations, the result changed dramatically. It was very nice in the end. I hope you like what you see. Good posterior occlusion, nice aesthetic outcome. We have been able to level the lower AOSC, which is also very important for long-term stability. And this is before and after smile. Of course, these patients have to be treated in a team of orthodontist and restorative dentist. And apart from providing our patients with excellent smiles, of course, we always have to think about function as well. And we would like to see canine rise in these patients. What else? Well, probably a special patient you might not encounter in your offices, where we're dealing here with missing teeth due to agenesis. Of course, it's a patient where something is missing congenitally. Take a look at the post-treatment close-up. I would like to challenge you to see which tooth is which here. This is Dominic. He came to see us at age 11, a class 2 patient who had already received some sort of premature first phase treatment. You can tell it by the broken retainer. Class 2 malocclusion, and this is what is happening in his mouth. Besides the bilateral agenesis, you will see that he is affected by bilateral transposition of the canine and the first premolar, which is relatively frequent, these transpositions in patients that present with agenesis of the lateral incisors. Of course, there are many ways that lead to Rome in these patients, but I have told you that we would like to keep it as simple as possible, or to do less for more. What is the way forward? Well, maybe you know Eva Szarowska. She is the world expert of autotransplantations. She has published a lot on the autotransplantation of premolars into the sites of congenitally missing lateral incisors. And she has a very long and exhaustive long-term follow-up in these patients. And we thought that when it is possible to transplant the bicuspids into the area of the missing upper laterals, maybe it would be possible to just conserve the transposition in Dominic, leaving the first premolar in the position of the lateral incisor. And once this decision was made, the orthodontic treatment was really a walk in the park. It was a little cumbersome to bring the canine down in the second quadrant, but once the canine was in the mouth, we could proceed with a very straightforward, straight wire system here, as you can see, closing the residual spaces. Of course, we had to occlusally equilibrate a little bit the palatal cusps of the first premolars in the position of the lateral incisors. This is how we finished this treatment, with some in-office composite restorations on the first premolars. Total treatment time was relatively short, despite the impacted canine. And here is now Dominic 10 years in retention. We would always like to show you long-term results if possible. We always invite the patients to come to our office on a long-term basis, offering some free oral hygiene to them so that we are able to shoot some long-term photographs in them. In the meantime, the composite restorations have been substituted by ceramic veneers, but the overall treatment result here is stable, smile is nice, and Dominic is very happy that he has his premolars in the sites of the congenitally missing lateral incisors. And as I said, we always have to show that we didn't harm our dentition in terms of root resorptions or not good root parallelism. Of course, the lower wisdom teeth had to be removed because we want to finish with 28 natural teeth, while the upper arch, due to the mesialization, we have sufficient space for eruption of the third molars. So again, a good example of 28 natural teeth in the mouth of our patients post-treatment. And this is again where we started with this post-treatment close-up, and it's really difficult to see that the first premolars are substituting the lateral incisors. So closure is generally preferred, but there may be exceptions. This could be an exception. Alice came to see us at age 15, and you can see she presents with generalized spacing, small dentition in a large arch, bilateral agenesis again of the upper laterals. And bearing in mind what Sheldon Peck told us, that it's always better to work with nature, and Wick Alexander to keep it as simple as possible, we thought that we would like to maintain the projection of the upper and lower incisors exactly as it was. Of course, we are aiming at symmetry. This is very important, but in Alice's case, we decided to open the spaces, as you can see here. We were able to open them nicely and parallelly. Treatment was relatively short, and of course, we think biologically, but we also have to think aesthetically. And if you consider a little bit the inclination of the upper incisors before treatment, here during treatment, and after the end of treatment, I think the idea of preserving the initial position of the incisors was justified. And of course, I'm not reinventing the wheel. We have learned already a lot about macro aesthetics, mini aesthetics, and that micro aesthetics are very important if we want to provide our patients with an optimum aesthetic result by the great David Sauber. So for Alicia, the idea was to open the spaces and to insert some zirconia cantilever resin bonded bridges, which are a very good idea nowadays. There's a lot of evidence in the literature to prove that this is a good concept. Take a look at the transition area after the insertion of the cantilever resin bonded bridge. I think it looks very natural. I think nobody of you can detect that the lateral incisors are replaced by cantilever resin bonded bridges. Matthias Kern, he is the head of the Department of Kiel University in Germany, has published a lot on these devices, and he has been able to show excellent survival and success rates 15 years down the road. So these Maryland bridges are not anymore considered temporaries, but they are considered the final restoration in these patients. Again, a look at the transition area, a look at the smile. We think that in certain occasions, opening of the spaces of missing lateral incisors could be very appropriate. What are the alternatives? Are we still considering single-tooth implants in the aesthetic zone? This is Dennis Tarnow, one of the world-leading experts on the topic of single-tooth restorations in the aesthetic zone. We have performed a study in 2015 because there existed already a study from 2005 by Armbruster and co-workers that proved that implant-borne crown restorations were not as aesthetic as Maryland bridges or as orthodontic space closure. And here you can see a little bit the patients that we examined with orthodontic space closure versus patients that had been treated with space opening and implant-borne crowns for substituting the missing lateral incisors. And our study, in fact, could reveal that over the last 10 years, significant improvements had been made, and that implant-borne crowns replacing the lateral incisors were judged much more aesthetically than 10 years ago. Why? Because the implantologists have learned some lesson going through their own cases, especially examining the immediate implant mistakes they had committed in the past. They know that the implant should be placed more palatally in order to avoid looming problems like vestibular bone loss. Of course, if you place the implant too far to the vestibular aspect, you are risking these bony resorptions and these very unaesthetic discolorations. If you don't place the implant right in the middle between the adjacent teeth, you might risk papilla loss. So the implantologists have learned that over the last decades. And we have now 5 requisites, and if you follow these requisites, you will be able to achieve nice results, even with implant-borne crowns in the aesthetic zone. If you insert the implant more to the palatal aspect of the cortical bone, if you try to adhere to the 2B3D rule, which means that 2 millimeters of vestibular bone coverage are mandatory, and that the implant is placed 3 millimeters in depth to be able to mimic correct natural biological width. If you finish with a ridge after your orthodontic space opening that is insufficient, like in this patient here, sometimes soft tissue or hard tissue bone grafting is necessary in order to build the ridge up. Again, as I said before, of course, the implant has to be placed right in the middle of the adjacent teeth, which means that you as an orthodontist have to open the spaces nice and parallelly and sufficiently in order to provide your implantologist with enough space. And what is extremely important is that the tissues have sufficient time to mature. So molding is very important with some provisional crowns. Give the tissues time to mature. This is the right way forward. We have then conducted a study with these patients that I have shown you clinically some years down the road. And we have not only assessed the pink and the white aesthetic score in this patient that had been treated with either orthodontic space closure or opening of the spaces for implant-borne crowns, but we have also assessed the papillary fill in these patients And we found out that there was no difference, neither in the pink and the white aesthetic score on the papillary fill, between patients that had been treated with orthodontic space closure versus patients that had been treated with implant bone crowns. And the patients, as we have given them a visual analog scale, were equally aesthetically satisfied. The amount of bone that got resorbed after 8 years of the implants in place was very, very low. So the overall treatment result was good. But we have the problem that has been described by Professor Thienlander very extensively, which is intra-occlusion, meaning that our dentition changes. There are always vertical changes, even in adult patients, so that over time maybe a difference between the position of the implant and the natural dentition can occur. Interestingly, Professor Thienlander in her articles wrote that only a minor or no infraocclusion was observed in patients with good interincisal stability, which is a good thing, because if we can provide our patients with good retention protocol and keep the results nice and stable, maybe we can limit the extent of intraocclusion very, very much and provide them with excellent long-term results, even if implants are placed in the aesthetic zone. So for patients above a certain age, usually the cutoff is 35 in our office, like Lorena, we still think that implant bone crowns have their field of action. You can see that she is a pseudo-progenic patient with not sufficient projection of the upper incisor. She presents with unilateral genesis of the right lateral. Superclass 1 occlusion, which is typical for pseudo-class 3 patients. She has retroclined incisors, and the prosthodontist asks us to open the space for being able to insert an implant bone crown. Reina already had an orthodontic treatment, was not very happy with the results, and was eager to perform a second round of treatment. You can see we were able to open the space, and nice and parallelly, which is important for implant insertion right in the middle between the adjacent teeth. It was not necessary to perform a bone graft on her, just a soft tissue graft in order to augment the ridge a little bit further. Here you can see the before situation after space closure and after implant placement. And then what I said at the beginning, it's very important that you give the tissues time to mature. Molding is very, very important if you want to finish with a very natural looking implant bone crown. You can see that with good control of the top, we were even able to get some spontaneous remittance of the generalized gingival recessions she presented. And here again, a little bit of the story, before treatment, after space opening. You can see that provisional crown has been placed in order to mold the tissue nicely before the final restoration was placed. Again, I owe you the panoramic x-ray to prove that we haven't jeopardized the integrity of our dentition. Implant was placed right in the middle, and if you take a look at the smile, I think the decision to open the space was very good for her. We gained a little more projection of the upper incisors, as you can see here, and even a closer look at the details will not reveal that the lateral incisor in the first quadrant is an implant bone crown. This is some years later, and I challenge you to see that the lateral incisor is an implant bone crown as well, taking a look at the transition area, which is the crucial area you have to evaluate when we talk about the aesthetic zone. Not every implant in the aesthetic zone must be a failure. This is an old patient of us who came to us not only because of her